to introduce our speakers of this session.
Next speaker is Dr. Paul Zimet. Dr. Paul Zimet is a professor of diabetes at Monash University and formerly director emeritus Baker Heart and Diabetes Institute, Australia. He is the honorary president of International Diabetes Federation and has an extensive international record in diabetes and obesity research. His research predicted and has charted the evolving global type 2 diabetes epidemic. Dr. Zimet is renowned for his contribution to understanding gestational diabetes and in the field of circadian rhythm and diabetes. So over to you, sir, Dr. Paul Zimet.
To be able to talk at this very important conference, the International Conference on Diabetes from Pune. The main theme of this relates to the fact that the circadian rhythms we have play a very important role in our health, and it's an area that is not really covered adequately yet within the medical environment. The circadian rhythm has a number of features as shown in this slide, the sleep-wake cycles, the body temperature control, mood, neurobehavioral processes, and also widespread metabolic effects. There's a role of the clock genes, and there is a body clock, which we'll discuss. And it's worth noting that circadian medicine did feature in a recent Nobel Prize in 2017. So we have a body clock in the brain area, and there are body clocks in all the major organs in the body and even in cells. And you can see here from this slide, there's a muscle clock, liver clock, gut clock, brown adipose tissue clock, pancreatic clock, and a cartoonist who I know of prepared this slide of the kidney, indicating there's many clocks on there, but the kidney has a body clock, as does the liver. These clocks are very important in controlling widespread metabolic processes in the body. Now, the big question is, of course, is why do we need an endogenous body clock? And Albert Einstein gave the best answer. The only reason for time is so that everything doesn't happen at once. And even in the very early century-old Chinese legends, we know of the body clock. Here is an example of a cartoon, and it just shows you at different times of the day, there are different functions. When you wake up, what your reaction time will be, when your greatest cardiovascular efficiency occurs, when your blood pressure is at the highest, when your body temperature is at the highest. Here past midnight, deep sleep, lowest body temperature, melatonin secretion, bowel movements, high testosterone, highest alert. A very important recognition going back centuries. Now, why is there so much controversy about the metabolic syndrome? Well, the metabolic syndrome, we face many big challenges. Is it a syndrome? What about the lack of uniform definition, the lack of known or single causation, and is it actually clinically useful? And some people wonder whether it really exists at all. And I'll be covering some of these concerns in my presentation. The two papers here are very important. The first one, the Metabolic Syndrome, appeared in The Lancet in 2005 by Professor Eckel and Grundy from the United States and myself. Amazingly, it's had 7,765 citations, very well cited, and it goes into the history of the metabolic syndrome. The other paper is by two well-known scientists from India, the late Shaukat Sadikot, and Professor Misra in the Diabetes and Metabolism Syndrome clinical research and reviews, and they actually raised the question whether the metabolic syndrome is an exercise in utility or futility, and I'll cover some of the issues that they themselves raised, which are real concerns. Now, the Eckel paper that I was involved in pointed out that the metabolic syndrome has existed in various forms and definitions for more than 8 decades, but it's only in the last 5 or 6 years, that there's been controversy and concern about its definition and significance. Also, the main controversy is that there seem to have been too many definitions of the syndrome, and I'll come to that issue in a minute, because it really raises questions about its role and value in clinical practice. And there was therefore a very strong call for a global definition, and along with the two characters shown here in this slide, Professor Eckel on top and Professor Scott Grundy below him, along with Professor George Alberti and myself from the IDF, we were involved in actually a new definition. But before I do that, I'd like to point out there are a number of different versions of the metabolic syndrome being used around the world, from the ICD to the WHO, the American Heart Association, the IDF, the ADA, etc. And as you can see here, in the different forms of the metabolic syndrome, we see that different of the risk determinants are present. In some, like the WHO 98, nearly all of these listed here on the side are present. In others, like the IDF's first definition, again, a number of key things that we regard now within the syndrome, like high triglycerides, the central obesity, and glucose intolerance, were not included. So this has been a very confusing picture when trying to compare rates of the metabolic syndrome in different countries and regions. And we came up, published in Circulation, on a harmonized definition of the metabolic syndrome. This involved the International Diabetes Federation, the National Heart, Lung and Blood Institute at NIH, the American Heart Association, the World Heart Federation, the International Atherosclerosis Society, and the International Association for the Study of Obesity. And here are the authors listed, George Alberti leading the charge, and I was also involved in this. Now, that particular definition basically covered the indices shown here, the low HDL cholesterol, central obesity, diabetes and impaired glucose tolerance and impaired fasting glucose, high triglycerides and hypertension. And it's had a number of names. It's been called Syndrome X by some, the Deadly Quartet by others, Awesome Foursome. Again, these different three names actually cover different of the indices that we use. Now, what are the key clinical outcomes of the metabolic syndrome? Well, clearly cardiovascular disease is a relative risk of 2, type 2 diabetes, a relative risk of 5, but the outcomes of the metabolic syndrome also include fatty liver, obstructive sleep apnea, depression and cognitive dysfunction, which are not included in the definition of the metabolic syndrome and clearly would influence even more perhaps the relative risks. One major one, of course, is the sleep problem, and here is the issue of obstructive sleep apnea. This cartoon, the guy recording there says, "I'm right there in the room." Oh, sorry, it's the elephant this time. "I'm right there in the room and no one even acknowledges me." And we now know what a leading risk factor it is for a number of chronic diseases. And shown here is just a brief description, a document by the IDF on the relationship of sleep apnea and type 2 diabetes, which I was involved in. And sleep apnea is very costly. It's been estimated that in 2015, it cost $150 billion in the United States. Workplace accidents, motor vehicle accidents, lost productivity, and comorbid disorders, which of course includes diabetes and heart disease. And just here we show that poor sleep has a lot of effects on health and economic outcomes. It's a major public health issue that receives minimal attention, yet it's a major risk determinant for a number of childhood things such as education and behaviour, brain development, depression, and it's involved in sleep apnea, as we mentioned, cognitive dysfunction, and car and industrial accidents. But it's very rarely recognised seriously the big impact on type 2 diabetes, obesity, heart attacks and stroke, and hypertension as major chronic disease disorders. So what about the big debate? What's the underlying cause of the metabolic syndrome? Well, there are contributing causes of the metabolic syndrome that have been drawn out in discussions over the years: abdominal obesity, insulin resistance, leptin resistance more recently, physical inactivity, advancing aging, endocrine dysfunction, and genetic factors. The real controversy comes on the issue of insulin resistance. And in his excellent Banting lecture at the American Diabetes meeting in 1988, the late Jerry Reaven postulated that it was insulin resistance and hyperinsulinemia. He in fact called the syndrome at that time Syndrome X. And he claimed that these were the driving factors of the cardiometabolic syndrome, and why these risk factors actually clustered together to cause the metabolic syndrome and the subsequent risk on chronic diseases. Well, what wasn't thought about was what in fact was driving the insulin resistance. And that's what I'd like to talk to you about now, because, and you can see here, some of our colleagues have got a box over their head, and we say maybe we should try to think out of the box and think what else there may be, or what may actually be driving the insulin resistance. So we head, of course, to our innovation department. So what could be the central driver and the common cause of the cluster? In Nature Medicine 2006, the Bart Stiles, a well-known European investigator, said, when the clock stops ticking, metabolic syndrome explodes. This was in Nature Medicine. And in 2008, Peter Grant, a well-known United Kingdom researcher made the statement, the clock stopped ticking, never to go again. And this was sort of in relation to, obviously, the body clock. One of my major research interests over the last decade or so, but it extended back to much earlier times when we started to research this little gerbil, Synomos obesus. It's the Israeli sand rat, better known as that. And that gerbil, when it goes out of the laboratory in Jerusalem into the desert in the south of Israel, it gets an elevated blood sugar, it becomes obese, it develops type 2 diabetes. It actually, we discovered in our research, it suffered from depression and sleep disturbances and also fatty liver. And one of the reasons for these outcomes is the fact of its diet, because it goes from a very salt bush type diet in the desert to a healthy gerbil diet in the laboratories in Jerusalem. But one of my colleagues, Professor Noga Kronfeld-Shaw, who's one of the world's leading researchers in circadian rhythm, pointed out to me that it was not just the diet, it was the change of the fact that these gerbils were underground most of the time, but in the laboratories they were exposed to light all the time and had upset circadian rhythm. And when we actually look that all these features do exist in these Synomos animals, including circadian dysrhythmia, we find that type 2 diabetes in humans, we see elevated blood sugar, obesity, depression, sleep disturbance, fatty liver, and it's well documented now, the circadian dysfunction as well. And this gerbil is a wonderful model, not only to study type 2 diabetes, but circadian dysfunction. So if we just go back to the metabolic syndrome now, and we note the risk factors involved in the definitions, but also that there are comorbid situations, sleep apnea, depression, and NASH. If we then include these in a definition along with the risk factors, or the cardiometabolic risk factors, we come up with what we have now put forward as a new concept called the circadian rhythm. So here we go. So these are the features of circadian rhythm, or the circadian syndrome, I should say. And on the side here, we have glucose intolerance, obesity, dyslipidemia, sleep disturbance, depression, cognitive dysfunction, and fatty liver. And you may not all be aware, but each of these have a circadian link and can be affected by circadian dysfunction. And we published this in about 2 years ago now in the Journal of Internal Medicine as a new way ahead in terms of studying circadian dysfunction, metabolic syndrome features, and of course the chronic disease outcomes. Now, if we look at the metabolic syndrome, and here's a nice picture of a Russian gentleman with the metabolic syndrome, sleepy, obese. When we see patients with a metabolic syndrome, we don't think of the fact immediately of the link also with sleep apnea, central obesity, depression, and fatty liver in these people. And we go ahead and address the risk factors we just accept as what people say is part of the metabolic syndrome, and may ignore features which enhance considerably the cardiovascular risk. And the point about this is that, again, I think we have to start thinking about the metabolic syndrome in a much wider concept. So, to me, the metabolic syndrome, the old definitions are redundant, and we should be really looking at this cluster. The metabolic syndrome, original risk factors, plus the more modern ones, so to speak, and that this is the major driver of the global chronic disease burden. Taking a view of the circadian syndrome, it provides a new focus on the underlying pathophysiology of the cardiometabolic cluster and the need for therapeutic approaches to NCD treatment and prevention. And the cost and burden of illnesses and accidents globally due to circadian disruption is now a major public health issue, not properly recognised until recently. We need to spend more time educating medical students and our own colleagues about the impact of circadian disruption, particularly during this pandemic where it's so prevalent, particularly in lockdowns. And we need to recognise, as has Dr. Sachin Panda has produced a wonderful book called The Circadian Code, which goes into much heavier detail about what I'm talking about today. So what we need to look at now is the possibility that a better understanding of circadian dysfunction may be a means of better control of drug therapy, providing medications at the correct time of the day when the metabolic function, for example, that it looks like that lipid metabolism is more in the late afternoon, and it's appropriate to give your statin therapies in relation to this. And there's already a circadian-related medicine that's been developed for it's bromocriptine, developed for treating diabetes, and it has other cardiometabolic effects. So the circadian syndrome, we predicted that would be a better predictor of cardiovascular disease than the metabolic syndrome. So working with Professor Zhu Minxi, a well-known Chinese worker in Qatar, we got a large database of Chinese people and looked at the comparison of cardiovascular outcomes in terms of the definition. Use one lot with the metabolic syndrome, another with circadian syndrome. And last month we released a paper, The Circadian Syndrome Predicts Cardiovascular Disease Better Than the Metabolic Syndrome. This is the picture abstract that the journal actually requests along with the paper. And the conclusion of that particular paper indicates that both the metabolic syndrome and the circadian syndrome, even though they both predict cardiovascular disease, that in fact, by adding sleep quality and depression to the metabolic syndrome construct to create the circadian syndrome, it's a better and likely to be a cost-effective and health-effective approach to enhance the prevention of cardiovascular disease. So I'd like to acknowledge in particular, I've had a long track record in the metabolic syndrome going back maybe 30 years, and the people here, Professor George Alberti, who will be well known to many of you, Scott Grundy from the United States, Bob Eckel, who is now president of the American Diabetes Association, and the late Jerry Reven, who I had many arguments about at various meetings about what actually was the driving factor or factors behind the metabolic syndrome, and that in fact his decision that insulin resistance was the driver ignored the fact that nearly all of the features of the metabolic syndrome at that time had a circadian component. And I think it's now very timely that we actually start to think about the fact that circadian medicine has not been recognized seriously on a wider basis, is a major factor in our global chronic disease epidemics. And I really want to thank you for
And I would request you to stay with us till the end of the session when we can have questions. So next speaker I would like to call upon is Dr. Juliana Chan. She will be presenting youth onset LADA case-based learning from published research. Dr. Juliana Chan is an internationally acclaimed clinician and researcher. She is the founding director of the Hong Kong Institute of Diabetes and Obesity, and is a professor at the Prince of Wales Hospital, Chinese University of Hong Kong. Dr. Chan is a member of the steering committee for the prevention of non-communicable disease in Hong Kong. For her outstanding contribution, the ADA conferred the Harold Rifkin Award on Dr. Chan in 2019. Over to you, Dr. Chan.
Ma'am, you must got a notification. Ma'am, you have got a notification to unmute yourself.
Okay, thank you. Yeah. Okay, so first I would like to thank the organizing committee, particularly Dr. Yuni, for inviting me to speak at this symposium. And it's great to meet Paul Zimmet actually virtually, and to listen to the Circadian syndrome, since we've been, working together on this metabolic syndrome for a long time. And I also want to thank Dr. Yuni for inviting me to give this talk, because it sort of reminds me some of the old research that I have conducted together with Professor Paul Zimmet some time ago. And so I was given this topic to talk about young onset LADA. So I think we've just heard from previous speaker how challenging the diagnosis of diabetes is. Diabetes is really a very complex disease. It has both genetic and also environmental and lifestyle factors. And particularly, I think in the young people, the classification really needs to be revisited because, as we heard, getting the diagnosis right is really the first step to good therapy. When it comes to type 1 diabetes, when we actually look, when a patient presents, we can classify them based on, clinical presentation. That is really the easiest way to do. And that is a classical type 1 diabetic presentation, where these people present with very heavy ketonuria and also diabetic ketoacidosis. But with increasing recognition, sometimes these people did not deteriorate all the way to diabetic ketoacidosis, but then these people are really requiring insulin continuously within a short period of diagnosis. That is certainly many years ago. This is I believe many clinicians who do not have access to biomarkers like C-peptide antigen will be relying on that kind of definition. However, we also know that not all people with type 1 diabetes actually have autoimmune type 1 diabetes. On the other hand, we also know that people who do not have the classical type 1 diabetes, the classical type 1 diabetes presentation, actually some of them may have autoimmune type 1 diabetes, and that some of them, may require insulin early. Essentially, these three things, these three kind of features are not actually mutually exclusive, and very often they overlap. And of course, the UKPD has already told us a long time ago that even in this rather middle-aged to late middle-aged to old people with type 2 diabetes. Actually, about 12% of these people have antibodies, either the GADA or the islet cell antibodies, and that's 4% of these people might have both. And that these antibodies actually predict the early requirement of insulin. And these people might never really have DKA. And of course, more recently, the Swedish group have come up with this very nice paper, have been widely cited, widely publicized, that we really should be reclassifying diabetes. And here we have 3 types of diabetes. You have the type 1 diabetes, okay, but this is a very small fraction. You have the LADA, the late onset autoimmune diabetes are adult. Then you have the classical type 2 diabetes. But if you use the GAD antibodies, the age of diagnosis, the BMI, the A1C, as well as using C-peptide and also C-peptide and glucose to derive the HOMA-IR and HOMA-beta, you can essentially put them into 5 groups. And these are the very 2 important outcomes when it's time to CKD and one-to-time insulin. And not unexpectedly, those people who have got severe autoimmune type 1 diabetes require the insulin early. This is followed by those with severe insulin deficiency diabetes, but they are not actually autoimmune mediated, although we also know that a lot of the autoantibodies might have disappeared by the time of presentation. And important to note that actually people who are more likely to develop CKD are those who actually got insulin resistant. Okay, these are severe insulin resistant diabetes. Very often these are people who are obese, followed by the mild age-related disease, and that of course highlight the impact of aging on development of kidney dysfunction, and followed by severe insulin deficiency diabetes. So here we really have 3 major players, that is insulin deficiency, insulin resistance, as well as the factor of age. And that of course makes people with young onset diabetes extremely vulnerable. So here in this paper, using our diabetes register, more than 10,000 people followed up since 1995, we're able to demonstrate this young onset type 2 diabetic patients. These are arbitrarily defined by diagnosis before the age of 40, compared to those people who were diagnosed after the age of 40, that these young onset type 2 diabetic patients at any one time, they have about 50% higher risk of events rates. And that's actually all the events were actually brought forward by about 10 years. So that even by the age of 60, 20% of these people will have died or have major cardiovascular events. So when we see somebody, a person, not only the age, it is really the age of onset of diabetes that is the most important question to ask, because the duration of diabetes is really driving a lot of the complications. But then we will actually look at the whole cohort. Then actually we found out, at least in our setting, the people with type 1 diabetes, and these really only account for 3% of the whole population, and accounts for only 10% of the type 2 diabetic, young onset type 2 diabetic population has the best outcome. Among those young onset type 2 diabetic patients, so those people who are obese actually also have a worse outcome in terms of cardiovascular renal complications, followed by the lean young onset type 2 diabetic patients. But these patients who have a less acute presentations actually have considerably higher risk of complication compared to people with type 1 diabetes, the classical presentation with ketotic presentation, suggesting that really type 2 diabetes, especially in the young people, are no less severe than the classical autoimmune type 1 diabetes. And of course, this form of young onset diabetes, we've heard from previous speakers, are very common, at least in Asia. 1 in 5 Asian patients actually were diagnosed before the age of 40. And it was really this phenotypic heterogeneity of these young patients, which are not uncommon in our locality, that's motivated us to set up the diabetes register. And in fact, when I first came back to Hong Kong, and I saw all these patients, I really had no idea what they are, because they didn't fit in with any of the textbook classification. I started sort of systematically trying to study them, and I was very honored to have the collaboration from Professor Paul Zimmert when he and Dr. Rowley at that time developed the anti-GAD antibodies. So at that time, we actually identified not many patients, but these are at least 30 classical type 1 diabetic patients, usually history of ketosis, DKA, continuous insulin requirement within 12 months of diagnosis. And all of them, we actually did C-peptide test. We actually give them 1 milligram glucagon IV, and then we define insulin deficient status actually less than C-peptide less than 0.6 nanomoles per liter at 6 minutes. And here you could see that these are relatively young people, only 34-year-old. We can divide these classical type 1 diabetic patients or people with type 1 presentations, into two groups. About 75% of these people were, 75% of these people were insulin deficient. Okay, 25% of these people were not actually insulin deficiency based on the C-peptide level. These people have actually 6 years of disease duration. So in other words, in these people who previously have who had a ketotic kind of presentation or continuously requiring insulin, actually, 1/4 of them were actually not that insulin insufficient. These people who were not so not the non-insulin deficient group, despite having the type 1 presentation, actually were a little bit more overweight, and of course they were more hypertensive, they also, although you could see that the mode of presentation are really quite similar between the two groups, all of them actually have ketosis. 70% of them presented with DKA, and all of them actually require insulin within 1 year diagnosis. But at the time of analysis 5 years later, 20% of these people who have actually got type 1 presentation were actually treated with oral drugs. And if you actually look, the A1C is a little bit better in those people who are non-insulin deficient, although they also have worse renal function and also worse albuminuria. Again, these are really looking at their C-peptide level. Here you could see that, again, after 5 years of disease duration, these classical insulin deficient type 1 diabetic patients, they have very low C-peptide at baseline as well as post-challenge, whereas these 25% of people actually have some residual C-peptide level. And you could also see that actually in these insulin deficient type 1 present patients, they have fairly high anti-GAT titer. Is actually defined as 18 as actually positivity, whereas for the non-insulin deficient type 1 patients, their anti-GAT titer was low. So the key learnings from this small survey really tell us that 1 in 4 young patients with type 1 presentations are non-insulin deficient after 5 years of disease. These atypical type 1 diabetic patients were more obese and had higher triglyceride. The majority of these atypical type 1 diabetic patients did not have high LADA titer, and as such, the combination of moderate insulin insufficiency and glucotoxicity may lead to the acute presentation. And when we look at the titer, the antibody, and also clinical phenotypes, you could see that people who were younger, who were leaner, who have younger age of diagnosis, who have actually got lower C-peptide level and also lower blood pressure, were more likely to have high anti-GAT levels. And this is again shown in this figure, showing that people who have actually got low anti-GAT titer actually are more likely to have more like a metabolic features rather than autoimmune features. So, so this kind of heterogeneity, the phenotypic heterogeneity of the type 1 diabetic patients, lead us to then ask the questions, what about if we just look at young patients and see what are the status in terms of the clinical presentations. And here we now look at, we look at 140 young patients. All these patients really have only age of 30 to 40. And here you could see that among these young patients, 12% of them actually have anti-GAT. And again, compared to those who were anti-GAT negative, they were slightly early age of diagnosis. They again have less cardiometabolic risk factors. They have less cardiometabolic risk factors, and also let me see, and And then when you look at those patients who actually get anti-GAT positive, 50% of them have an acute presentations. But about half of these anti-GAT negative patients also have acute presentation, or they were treated with insulin. So you could see that these patients were heavily treated, where half of them were actually treated with insulin. Half of them also have acute presentations. So, however, the LADA patients, okay, these anti-GAT positive patients, they have worse glycemic control, 9% A1C compared to 7.6% in those who are anti-GAT negative. And they, on the other hand, the anti-GAT negative patients, they actually have worse cardiometabolic profile. Again, if you look at the C-peptide level, the C-peptide level, you could see that patients who were anti-GAT positive have considerably lower insulin reserve, okay, as defined by the C-peptide level, as compared to those who were negative for anti-GAT. So 50% of and if you look as definition of insulin deficiency, both the anti-GAT positive and anti-GAT negative patients actually have insufficient insulin secretion. Okay, so put it together, 50% of both the anti-GAT positive and anti-GAT negative patient has severe insulin insufficiency, and as such, other non-autoimmune causes will contribute to the insulin insufficiency in young patients with diabetes. However, if we look at the age of diagnosis, then people who have younger age of diagnosis, they are also more likely to have anti-GAT positive. But actually, and so in those people who are diagnosed over the age of 20 or so, then I think these people, whether they have type 1 presentation or whether they have insulin insufficiency, then other causes need to be sought. And of course, now we know monogenic diabetes and other genetic factors might contribute to this degree of insulin insufficiency. And these genetic factors might interact with, or perinatal factors might interact with genetic factors, as well as environmental and also lifestyle factors, to give rise to this early presentation. So putting that together, so we really now have to consider three variables: the GAT status, the anti-GAT status, the C-peptide status, and the type 1 and the sort of ketotic presentation, in order to try and understand the causes and how they interact to change the trajectory, as well as the consequences. So really, for those who have the very, very classical type 1 presentation, are very, very few. In other words, with classical type 1 presentation, the positive anti-GAT status, as well as the low C-peptide level. But some of these low C-peptide level patients might or might not have type 1 presentation, might or might not have anti-GAT. And similarly, patients who have anti-GAT might or might not have acute presentation or low C-peptide level. So the ongoing collection of these patients and the tracking of the outcome has now given us new insights regarding the prognostic significance of anti-GAT in onset diabetes. And this is really a paper that we published last year, and really where we actually look at 1,755 young patients who have either type 1 diabetes. Again, the type 1 diabetes is defined as ketosis, a history of DKA, or continuous insulin requirement within 1 year of diagnosis. And then, we have the young people who have the non-type 1 presentation, but then we found that actually 8% of these individuals have anti-GAT. So here we now have this acute type 1 and the sort of late onset type 1, the more insidious forms of type 1, and then these are the non-type 1. So we have these three groups for comparison. Firstly, you could see that they're relatively young. Of course, the type 1 diabetics is a lot younger, but these people, they all have age of diagnosis really around about 2030. Okay, so And again, they have fairly similar in terms of disease duration. And of course, we know these are very important factors that may also contribute to insulin insufficiency. So they're given similar disease duration, relatively similar age. So I think that's important for us to interpret the subsequent findings. Family history-wise, as expected, people with type 2 diabetes actually have a stronger component of family history as compared to type 1 diabetes. Only 24% of these people gave positive family history compared to 50%. So so if we use the LADA, right, as the group, okay, the group that we're interested in, compared to the classical type 1 and then the non-type 1. So you found that actually patients compared to the type 1 diabetes, the LADA, of course, have later age of diagnosis, they have stronger family history, and they are more cardiovascular risk factors. You can see they're more obese, and they also have high blood pressure. However, when they compare to the classical type 2, they have similar age of diagnosis, but they are actually less obese and they have fewer cardiovascular risk factors. So the next thing is then you again look, they have similar glycemic control, not really very good, 8% overall. Generally speaking, the young people, we know they are the difficult one. They are the one who have worse glycemic control compared to the older age group. Of course, these 100% of these LADA patients have positive antibody, as compared to only 50% in these type 1 presentation patients with classical type 1 presentations. You could see that actually the C-peptide level is the lowest in these classical type 1 diabetes patients. In these patients, LADA, they also have relatively insufficient insulin level. Here, we are only using fasting C-peptide. Less than 100 is considered to be severe insulin insufficiency. And then if it is less than 200, it's also considered to be moderate insufficiency. So when you actually compare the type 1 diabetes and also the LADA patients have similar glycemic control. On top of that, they also have worse risk factors, although they have a little bit more C-peptide. Compared to the type 2 diabetic, they have worse glycemic control. They have fewer risk factors, okay, in terms of cardiometabolic risk factors, but they have lower C-peptide reserve. And if you look at the complications, these are the cardiometabolic risk factors presented at a different way. So again, the LADA compared to the classical type 1, older, more risk factors and complications. Compared to the classical type 2, they are younger, they have fewer risk factors and complications. If you look, however, although these people have autoimmune, confirmed to have autoimmune antibodies, compared to the classical type 1 diabetes, actually only 40% of these patients were treated with insulin. Compared to these patients with all type 1 presentations, they have classical type 1 patients, they have 100% treated with insulin. Although note that even the type 2 diabetics, actually 1/4 of them are treated with insulin, despite relative short disease duration of only about 4 or 5 years. And then you look at the pattern of drug usage, okay, they're quite similar between the two groups, despite the fact that actually the LADA group actually have a stronger component of insulin insufficiency. Now, if we actually look at incidence of complications, which is of course what we are interested in, and this is really expressed as per 1,000 person year. So these are the classical type 1, these are the LADA, these are the type 2. So compared to these type 1 and LADA, these young patients, remember these are young patients, mean age of only 40-ish, they have nearly 1% per year in terms of CVD. The two groups, okay, these are both the type 1, the LADA and the young onset type 2, they have similarly higher, similar rates of end-stage kidney disease, 0.5, about 10 per 100,000. About 10 per 1,000 person year, which is higher than the classical type 1 diabetic patients. Both the LADA and particular type 2 diabetic patients actually have higher death rates. But interesting to note, actually compared to the classical type 2 diabetic patients, actually both the type 1 and also the LADA have very high risk of actually severe hypoglycemia requiring hospitalization. And if we look at the risk ratio Again, after we adjust for a whole lot of parameters, age, sex, disease duration, all the risk factors, treatment, etc., you could see that actually the LADA compared to the type 2 diabetic patients, they have 2 times higher risk of severe hypoglycemia. But however, when you compare the LADA versus the classical type 1 diabetic patients, they have actually 3 times higher risk of end-stage kidney disease. Suggesting that actually because of the less acute presentations, these patients were less likely to be treated with insulin, they have worse glycemic control, and on top of that, they also get a bit of cardiometabolic risk factors, putting these patients at much higher risk of developing end-stage kidney disease. And these people also have high risk of hypoglycemia because obviously the autoimmunity would not just attack the beta cell, but actually the islet. And probably these people have both alpha cell and also beta cell dysfunction. And what's interesting is when we look at these data, we found that among these type 2 diabetic patients, the young type 2 diabetic patients, these 10% of LADA actually have higher A1C, but if they happen to be treated with insulin, they have a considerably good response. Okay, the A1C reduction is 2.3%. So these people really have insulin insufficiency as a predominant features, and so really it's important to give these people insulin rather than trying out different kind of oral drugs. Although sometimes they're also masked by the cardiometabolic risk profile. So really, making whereas the other type 2 diabetic patients, the response to insulin is average 0.7%. So in summary, I think based on these 3 studies, okay, which are really concentrating in young patients, at least the Chinese patients, Chinese patients, these are around about, less than 40 years old, and all have age of onset below 40 years old. There is considerable overlap between the type 1, type 1 ketotic presentation, the C-peptide levels, and also the anti-GAD status. 50% of the type 1 diabetic patients are LADA positive. Okay, this might be because of disappearance of the antibody with time, but we probably have to think of other causes that is associated with severe insulin insufficiency, for example, like mitochondrial diabetes, or even, for example, some of the MODY who might be missed, and so ongoing glucotoxicity might accelerate beta cell dysfunction, and then giving rise to severe insulin deficiency and acute presentation. 50% of the LADA patients are insulin deficient. Okay, so some of them still have residual beta cell function, raising the question, can we do something to preserve the beta cell before they frankly become insufficient with ketotic tendency? However, in these patients, despite their autoimmune status and also a low C-peptide level, only 50% of them are insulin treated. The larger patients have 2-fold higher risk of severe hypo compared to the young type 2 diabetic patients. However, they have 3-fold higher risk of end-stage kidney disease than type 1 diabetic patients. Larger patients are highly responsive to insulin treatment. So taken together, I think given the really phenotypic and also autoimmune and genetic heterogeneity of these young patients, I think the measurement of C-peptide and anti-GAD are really important to identify firstly this 10% of patients who really have autoimmune, etiology to be treated with basal bolus insulin. We also probably need the C-peptide for us to identify those people who are insulin insufficient and who might benefit just from basal insulin. Other causes will need to be identified to explain for the very high prevalence of insulin insufficiency in both the type 1 diabetic patients as well as the larger patients and the non-LADA type 2 diabetic patients for more precise diagnosis and treatment. Thank you.
This is Dr. Unnikrishnan, and so nice to see you, and greetings from India. We enjoyed your session on youth onset LADA and the case-based learnings from published research. And it was really illuminating, and I was interested to see the high prevalence of insulin deficiency and also that people with LADA are more prone to hypoglycemia. Could you tell us a little bit more about the diagnostic implications of LADA and how do you counsel patients with LADA? Because many of the people I see with type 1.5 diabetes LADA, they ask me, okay, doctor, so what's my future going to be, and how am I going to manage this? So could you tell us a little bit more that in clinic, how would you counsel patients with LADA about their disease and the history?
Well, you see, I think based on a wealth of data, we know that people with type 1, the classical type 1 diabetic patients, taking an example from the West, really many of these classical type 1 diabetic patients, they have autoimmune etiology. And so, the antibody attack not just the beta cells, but also the alpha cells. So really these people can very brittle, diabetes and basal bolus, obviously with the choice and if possible, insulin pump to try and mimic, the level. And the physiological pattern. And of course, to do this, we have the technologies now, but of course, the really more important is the education, right? So I think really intensive patient education, empowerment, and of course now with the CGM, it has also, make it easier because really the data are very important for the patients to adjust. So I think, and that, because these are of classical type 1, there are not that many and they don't default, because if they default, they get DKA. And at least in our situation, we have the diabetes center and the nurses manage them very well. So you could see that actually the outcome is very, very good in these classical type 1 diabetic patients. The LADA are actually very worrying because I think they get missed, okay? And of course, now we've got so many oral drugs. They actually are on the verge to actually developing frank insulin insufficiency. So the more oral drugs, but yet we are still not correcting the primary defect. Maybe, we have missed the opportunity of optimizing glycemic control. On the other hand, so I think, if these people really have C-peptide theta together with low C-peptide, then, I think basal bolus insulin is important. Along with all the monitoring and education. But I actually do come across some patients who have antigen positive, but they actually still have quite a bit of C-peptide level. So, that actually become quite interesting, and sometimes some of them also have fairly good A1C. So that's really, I think more, research needs to be done in these individuals. I think these people, probably the autoimmunity is not so severe, but I think in these individuals, even more important for us to optimize the glycemic control and also the reduction of body weight. That's what I tell them, so that they can preserve, right, their islets, so that they don't actually deteriorate so fast, because they are very vulnerable to deteriorate very rapidly because they have this autoimmune tendency. Just like, I think thyroid disease, right? We know a lot of people have Graves' disease. They have antibody, but they don't actually have frank Graves' disease. They may need additional component to drive it. And so this is really how we counsel them. Currently, we're doing a study where we systematically genotype everybody. We measure C-peptide antigen, we measure, all the MODY genes as well as all the GRAS. In these type 2 diabetic patients, these are young patients, irrespective of the form of presentation. And then we use this to counsel them and then really try and individualize therapy and see whether we can make a difference.
Thank you, thank you. And we have Dr. Paul Zimmet there. Are you there, sir, Dr. Paul Zimmet? We have a question for you.
Still here.
So just a question, in the evolution of the clock genes and the circadian rhythm, I think one of the pivotal, discoveries was that it was not just the brain or the eyes that were responsible for the circadian rhythm, but that different organs of the body had a different clock. For example, the pancreas had a clock, the liver had a clock. Do you see that as one point where this understanding of circadian rhythm and metabolic syndrome just took off, that science took off and is now expanding rapidly, which is the critical point, inflection point of the research that has led to this huge interest in circadian rhythm and metabolic syndrome understanding?
Look, I think it's a hard question to answer to a time, but it's not just the liver or the kidney. Every cell in the body has a clock, and it's all tuned against the brain clock. So any major disruption in relation, that upsets your rhythm, whether it's poor sleep or lack of exercise, what it is, has a poor effect. And most of the metabolic processes in the body are part of it. So it's actually a very highly integrated circuit in terms of circadian rhythm, and circadian disruption, of course, then affects a lot of processes in the body. And I think it's just really a big wake-up call. I think the last month's edition, or one of them, of the New England Journal of Medicine had a very large article on circadian medicine and circadian function. So it's a growing area.
Thank you. Thank you.
But I think that in India, people have always been thinking in this going back many centuries.
Thank you, Dr. Paul Zimmet and Dr. Juliana Chan. Fascinating listening to both of you. And now we have a very unique session called Language Matters Session. So, many years back when I was a doctor, a patient would come to me, or a person with diabetes would come to me, and the relatives would sit around the person and say, "Doctor, he's not eating, he's not listening to any advice, he's not exercising, he's always opening a pastry from the refrigerator and eating it." And then the doctor would say, I'm not saying I would say, I'm saying the doctor would say, oh, if you don't take your medicines on time, then, if you don't do diet and exercise, you might have to take insulin in future. So this was what was 10, 15 years ago, how we used to practice diabetes. But I think today, with the change in our own understanding of the psychology of people, the psychology of healthcare workers, the psychology of patients, the psychology of people with diabetes, how type 1 and type 2 diabetes are different, we have learned to be a little more nuanced in talking to people. For example, I try not to use the word diabetic. I try to use the word a person with diabetes or people with diabetes. I try not to be judgmental and try to make positive, remarks to the patient rather than, anything negative, so that can encourage the patient or the person with diabetes. So this is a very important, and this is a movement which is sweeping across the world. And the torch bearers of this movement in India are two young, dynamic endocrinologists of the country, Dr. Chitra Selvan and Dr. Tejal Latia. Could we have their CVs, please, on the screen?